Hi everyone, welcome back to Izzy Medicine. Today we continue our shock series. So let's start with our patient. A 62-year-old man with type 2 diabetes and obesity comes into your ER with fever, chills, and weakness. He tells you that his left leg has been red and painful for 2 days. Now he feels a little off and hasn't been peeing all day. On exam, he's drowsy, but he answers questions. He's breathing fast at 28 per minute. His heart rate is 110 and his blood pressure is 94/58. His temperature is almost 39 degrees Celsius. When you examine his leg, his left lower leg is swollen, red, warm, and it's starting to blister. You order blood work, and his white count is 15.8 with a left shift with some bands. His platelets are low, and in comparison to his already high creatinine, his creatinine is rising, and his lactate is at 3.2. This is where you start getting worried and think maybe this is septic shock. So let's talk through what septic shock really is, what's happening in the body, how to spot it, and how to fix it before the organs start shutting down. So what is septic shock? Septic shock is a kind of distributive shock caused by an infection. The most common bacteria are gram-negatives, such as E. coli, Klebsiella, and Pseudomonas, and gram-positives, such as staph or strep. What are our common sources? So skin and soft tissue infections, like our patient with likely cellulitis, urinary tract infections, pneumonia, intra-abdominal infections, and a myriad of other infections, but those are the common ones. What are the at-risk patients? So patients that are immune compromised, such as cancer patients on chemotherapy, patients that have indwelling catheters or central lines, such as elderly patients with urinary retention, or quadriplegics or MS patients that have an indwelling catheter for bladder emptying, our post-operative patients, our critically ill patients, or anybody with chronic conditions like diabetes, for example, like our patient. The key concept to remember in septic shock that it's not just the bacteria that causes the septic shock, it's the immune system response that goes into overdrive that causes the harm. So let's review this. When bacteria invade the body, immune cells don't just detect the bacteria that is alive, they also recognize fragments of bacterial cell walls, like lipopolysaccharides from gram-negatives and peptidoglycans from gram-positives. So this recognition triggers the immune system to act. Immune and endothelial cells start releasing chemical signals, such as cytokines, like tumor necrosis factor and interleukins, and also large amounts of nitric oxide. This is the important point to remember. This response of cytokine release and nitric oxide release is normal. During a regular infection, small local amounts of cytokines and nitric oxide are actually beneficial. What they do is they dilate blood vessels in the infected area. They make it easier for neutrophils and other immune cells to reach the site and to fight bacteria and start the whole healing process. So far so good. This is the normal immune system response. But in septic shock, the response doesn't stay localized. For reasons that we don't fully understand, some patients spiral into a massive systemic release of cytokines and nitric oxide. This response becomes dysregulated and goes too far. So instead of just opening blood flow where it's needed locally, these mediators dilate blood vessels throughout the entire body, they drop vascular tone everywhere, and they make the capillaries leaky. When this happens, preload falls, systemic vascular resistance plummets, and the body essentially starts harming itself, and what's supposed to be the immune system's normal protective response becomes dysregulated and destructive. And that's the real danger of sepsis, not just the infection itself, but the body's overreaction on a systemic scale. So let's dive a little further as to why perfusion fails. To understand this, we have to break this down into the components of mean arterial pressure. Let's remember this. Mean arterial pressure equals cardiac output times systemic vascular resistance. And what does cardiac output equal? It equals heart rate times stroke volume. So in septic shock, stroke volume falls because of the cytokine response. Plasma leaks out of the vascular space, and venous return, which is preload, drops. When we have less preload, the ventricles don't fill with enough blood to pump out with each beat. So even though the heart is beating hard and fast to compensate, the actual amount of blood ejected per stroke, or the stroke volume, is reduced. So if we have a reduced stroke volume, we have reduced cardiac output. Then we have a drop in systemic vascular resistance because nitric oxide and cytokines dilate the blood vessels and it makes them floppy. And this reduces our systemic vascular resistance. If we have reduced cardiac output and reduced systemic vascular resistance, this makes mean arterial pressure plummet. And with this mean arterial pressure reduction, tissues stop getting enough oxygen. What happens when tissues get less oxygen? So on top of the poor delivery of oxygen, the mitochondria, which is our beautiful ATP producing unit that is oxygen dependent, can't make this ATP efficiently without it. So we go into anaerobic respiration and anaerobic metabolism. And when the mitochondria goes into this anaerobic process, the tissues not only starve because of lack of oxygenation, but we have lactate build up as a byproduct, and we get into lactic acidosis. So when you see a patient in septic shock, it doesn't always scream shock at first. In the early phase, or warm shock, the patient may actually look flushed and warm with good bounding pulses. This is because the heart is still compensating with high output. It increases the heart rate and the blood supply is still being sent to non-vital organs. But we can't be fooled by that because under the surface, tissues are already starving. So we will see them looking for oxygen by breathing fast. They're also confused because their brain's not getting enough oxygenation. And they're making little urine because the body is not sending oxygenation to vital organs such as kidneys. So these are all signs of hypoxia and poor perfusion that we have to pay attention to. If you don't act quickly, the heart eventually can't keep up. It can't maintain cardiac output by just increasing heart rate because the stroke volume is reducing. So that's when we shift into cold shock because the cardiac output drops and the skin becomes mottled and clammy because blood is getting shunted to the heart and the brain as preference. And the blood pressure tanks even further and the organs start to fail. So in addition to recognizing the fact that our patient has signs of potential infection, how do we recognize this early? At the bedside, we can use the qSOFA as our quick screen. If the patient has 2 or more of these, we assume sepsis and we move fast. If we have a respiratory rate over 22, if we have altered mental status, and if we have a systolic blood pressure under 100, our patient had all 3, assume sepsis. Additionally, the labs, of course, help tell the story. So if our lactate that we drew is above 2, this is a big indicator. It's a big marker for hypoperfusion. As we reviewed briefly, when tissues don't get enough oxygen, they switch to anaerobic metabolism and they churn out lactate. So anything over 2 means trouble, and over 4, that's severe and a high mortality risk, and we need to move fast. Also, white blood cell count with a left shift with bandemia. The white count can swing both ways because the immune system is overwhelmed. So either we can have it high from an inflammatory response or dangerously low from this overwhelm in the immune system. In either case, the bone marrow releases immature neutrophils or bands, which is called a left shift. It means that the marrow is under stress and it's basically throwing everything it got at the infection, even baby neutrophils. We also get low platelets because sepsis activates the clotting cascade through inflammatory cytokines, and that chews up platelets in the process. What can happen is we can have thrombocytopenia, can be an early sign of disseminated intravascular coagulation, which is DIC. And this is where microclots form and bleeding risk increases. Additionally, we need to look at rising creatinine and LFTs because once we see kidney and liver numbers go up, you know the organs are already taking damage from hyperperfusion and microthrombi. Well, of course, we draw cultures, either blood cultures, urine, sputum, wound, to find what the bug is, but we don't wait to treat. Every hour counts. As a side note, in hypovolemic shock, we often calculate base deficit, and if it's more negative than -4, then that's a concern. In sepsis, a base deficit, which is calculated from arterial blood gases or venous blood gases, it's still helpful, but lactate is the main marker that we follow. So how do we treat this? We start with fluids. Fill the tank. We give 30 mLs per kilogram of balanced crystalloids like lactated ringers in boluses of 500 to 1,000 mLs over 10 to 30 minutes, and then we reassess after each bolus. What are we reassessing? We're looking for endpoints of reassessment. So we're looking for urine output to improve to equal or above 0.5 mLs per kilogram per hour. We're looking for mental status improving, so for our patients to become less confused. We're looking for that lactate to start dropping anywhere from 10 to 20% within 2 to 6 hours with serial lactate. And of course, we're looking for our mean arterial pressure to be equal or above 65. When we notice that our patient is stabilizing, we stop the fluids because overloading hurts too. We can cause pulmonary edema, electrolyte imbalances, dilutionary coagulopathy by diluting the clotting markers. Concurrently, we start broad-spectrum IV antibiotics within the first hour. Most hospitals use beta-lactam like piperacillin tazobactam or Zosyn plus vancomycin while the cultures are pending. Zosyn covers gram-negatives, Pseudomonas, and anaerobes, and vancomycin, of course, covers MRSA if it's suspected. Some settings substitute fourth-generation cephalosporins such as cefepime plus metronidazole if anaerobes are also a concern. When fluids are not enough, let's say our patient has a mean arterial pressure that stays below 65 despite adequate fluids, we start vasopressors. Norepinephrine is first line. Norepinephrine increases vascular tone through alpha effects, and it moderately supports cardiac output, and it has better outcomes than alternatives. Dopamine is often avoided because it carries a high risk of arrhythmias. It historically has worse outcomes, and it has unpredictable effects because it's very much dose dependent. If norepinephrine isn't enough, we add vasopressin to boost vascular tone via V1 receptors. Epinephrine is reserved for refractory cases because epinephrine can raise the risk for arrhythmias. It can increase myocardial oxygen demand, which we don't want because we're already struggling for oxygen. And lastly, source control. We stop what's causing it. We remove infected lines. We drain abscesses. We debride necrotic tissue. Whatever it takes is what we fix. So to summarize, septic shock is your immune system going rogue. It's overreacting to bacteria. It's flooding the body with cytokines and nitric oxide. It makes blood vessels floppy and leaky. It drops preload. It lowers systemic vascular resistance. And it starves tissues of oxygen, and it pushes organs towards failure. So it's not just an infection with low blood pressure. It's a full system overreaction. That's it, guys. That was our septic shock lecture. Thank you for watching. And don't forget to check the next episodes where we tackle cardiogenic and neurogenic shock. If you like this, please subscribe and click the like button and leave a comment. I'd be more than happy to interact. Until next time, stay calm and keep saving lives. Bye.